And then he worked as a carpenter for 40 to 50 years. During this time, he was exposed to a lot of sunlight, being burnt as a child, and a lot of sunlight throughout his career. He does have 1 pack per year smoking history for 20 years. And he doesn't have any headache or change in weight or change in vision, just a little bit of problem seeing in his right eye because of encroachment from the mass on his eyelid. And I do have to warn you, there are some graphic pictures in this presentation. So on the physical exam, it was a 4.5 by 4 centimeter lesion on his right forehead, and it was fixed, growing into the frontal bone. No problem with vision other than that encroachment. He did have some lymphadenopathy on his neck, just below the parotid gland on the right side. Cranial nerves 2 through 6 were intact, and 8 through 12 as well, but there was some invasion on the right side into the frontal branch of cranial nerve 7. The other physical exam maneuvers were normal. So here's the lesion here. You can see it's 4 centimeters by 4.5. This is on his right forehead. Here there's necrotic tissue, and as I entered the room, there was a distinct smell of decaying tissue there. And here you can see, we asked the patient to wrinkle his forehead, and you can see the right side, it's wrinkling, but on the left side, there's no innervation of that muscle there. So after he couldn't get treated at the university level, he was in the ER with his wife for an unrelated problem. An ER physician there saw this mass on his head and said, "Hey, I know this doctor in Rockford who has worked with the uninsured and she may be able to help you." He went there, she biopsied these different lesions, and he ended up having that squamous cell carcinoma on his right forehead. He had 2 other lesions on his nose that proved to be basal cell carcinoma, and also one on his left ear that was cancer as well. So 4 cancers on his head. As far as the risk factors for squamous cell carcinoma, UV light exposure, which our patient had, sunlight exposure in childhood working on the farm, our patient had as well. The blistering sunburns in childhood, farm work again. And then he had the phenotypic characteristics, very light complexion, red hair, freckles, blue eyes. And then here's some other risk factors that our patient didn't have but should be taken into consideration. So as far as the epidemiology, cutaneous squamous cell carcinomas are the 2nd most common type of skin cancer in the United States. 20% are non-melanomatous skin cancer, and they're the 2nd most common cancer overall in Caucasians. They're increasing yearly in incidence, and today they're estimated to be over 3 million annually. And just a little note, side note, cutaneous is different than mucosal cancer as far as location, risk factors, and there's different modalities for treatment. So here are some intraoperative pictures. Here you can see we excised that large mass on his forehead. We used a technique called the circumferential, peripheral, and deep margin assessment. And we sent that down to the pathologist, and they did frozen sections on that. And here, one of the margins came back positive, so we had to excise more skin there. Here, we had to drill some holes in his skull, some burr holes, so that we could cut out that bone. So here you can see that's the bone that the cancer was growing into. And here we're removing this bone so that we can cover that area. We also had to do a complete neck dissection because of that palpable lymph node in the neck. And the ENT doctor removed levels 1 through 3 and sent those for frozen section. So here is the dura mater. That's the layer covering the brain. So just under this is the patient's brain. We removed that bone. Here you can see is the good bone that we're going to use to reconstruct that. We took the outer tablet of that bone, left it connected to the aponeurosis, or the tissue connecting that bone to a blood supply. We took the lower tablet and we spread that out and put it right here. And we connected all of this with these titanium pieces. That way this bone had a blood supply and blood will diffuse to this to maintain the health of that tissue. So here, when we drilled the holes, we kept that dust and we pasted it in there. So eventually this will ossify and calcify and become a nice protective layer again. Here you can see we had to reconstruct those lesions on his nose. We did this using a left pedicled paramedian forehead flap that had two blood supplies, the supraorbital and supratrochlear. So here are just before we woke the patient up. We couldn't primarily close these defects, so we had to use Integra dermal layer, and at a later surgery we will cover those with a skin graft. And here's the first post-op visit, and that's healing up nicely. So I'll hand it over to Joe Brancheck.
Hello, as Logan said, my name is Joe, and I'm just going to go ahead and briefly talk about primary and secondary prevention of SCC, as well as a little bit about the treatment algorithm. So first of all, what is primary prevention? It's avoidance of the occurrence of the disease. So in SCC cutaneous type, mainly avoidance of excessive amount of sun exposure, and patient comes in the office, most important part is counseling and education, telling them about the risk factors of being in the sun too long. Avoiding midday sun exposure, very important, up to 60% of the sun's rays or energy hits the earth between 11 a.m. and 3 p.m. Wearing protective clothing to directly block the sun's rays. Sunscreen use, while helpful, it does not allow for increased time in the sun, and also it should be SPF 20, reapplied every 2 hours and water resistant. And then avoidance of indoor tanning. And then secondary prevention, what is that? It's diagnosis and treatment of early disease. So that involves screening. There's no consensus guidelines, but the American Cancer Society advocates screening every 3 years between 20 and 39, and yearly thereafter 40. Is one more aggressive treatment or screening regimens. And then counseling and education, again, if the doctor does see a lesion, it's important to explain the consequences of ignoring that and the treatment options available. Biopsy, that's often only done if the diagnosis is in question or if the depth of the lesion is in question, because that would involve different treatment methods. And then simple surgical removal is often the treatment at the early stage. And then there are also some non-surgical methods for the carcinoma in situ, the ones that haven't invaded and metastasized. There's topical chemotherapies like 5-fluorouracil, immunomodulators like imicamod, and then also some photodynamic therapy, radiation therapy. Radiation therapy is often only used as an adjunct to the surgical therapy, but it is useful for non-surgical candidates. And in areas where scarring is a concern, you can use radiation therapy, but it does have a lower success rate at treating the cancer, as well as longer time and expense. And then electrodesiccation and curettage and cryotherapy. And then just a quick overview of the treatment. Notice a suspicious lesion, do a full history and physical, a biopsy as necessary, and imaging studies as necessary to examine for metastasis in any lymph nodes. In our patient, there was a positive palpable lymph node, but that wasn't necessary. Then that will divide it into either local disease or metastatic disease, positive lymph nodes. Local can be divided low risk, high risk. And then there are just some treatment options. POMA just stands for post-operative margin assessment. And then MOS and CCPDMA on the other side is, as Logan has stated earlier, is complete circumferential peripheral deep margin assessment. And then positive lymph node often just requires surgical dissection. And then follow-up, main thing to take from this slide is just that either with local or regional disease, it's just more frequent monitoring, and then patient education again. And then risk of recurrence, just two things I want to point out. Tumor location and size, and in this specific case, this is the masked facies area. It has a higher risk of recurrence. And our patient did have the lesion right in this area, so higher risk of recurrence. Clinical border is important, primary versus recurrent disease, immunosuppression, previous irradiation, and then the perineural invasion is the other part I want to go over again. Like Logan has stated earlier, our patient did have invasion of the frontal portion of his facial nerve. This is him trying to wrinkle his eyebrows. Up to 15% of cutaneous SCCs can have perineural invasion, and this just kind of underscores the importance of doing a full cranial nerve exam when you think that a patient has SCC. And then importance of prevention overall. This patient, as stated earlier, didn't have insurance, delayed treatment of his SCC for 2 years. At 2 years, he required 8 hours of operation time, the expertise of a neurosurgeon, plastic surgeon, and an ENT. And then this is versus a simple office excision if he had come into the office and been able to have it taken care of. And then not only that is high cost and morbidity to the patient, but it's also a high monetary cost to the system. And then that's the end of our discussion. Here are some references. There's the treatment team and some questions.
I actually am going to steal the first question, I'm sorry. So I was wondering, because this patient had such an advanced stage of disease, I was wondering if, as part of your training, if the doctor that you were working with gave you any advice or tips on how to approach the patient or speak to the patient when talking to him and evaluating him.
As far as advice,
I guess for bedside manner, for clinical pointers.
The things that we learned from this case is some people won't have insurance, and there's kind of a loop, or there's a donut hole, if you will, in healthcare where the really poor receive healthcare and the rich can afford it. So I think one of the lessons you can take from this is you really want to, even if it's going to cost you a little bit of money, you want to take care of these things in people that can't afford it. And as far as your bedside manner, you always want to be respectful if they can't afford it or if they don't have insurance, and you want to give back as much as you can.
And then just to add on that, while not specifically with this case, but through our whole training, they really do emphasize, respect, compassion, care, and interacting with patients. Really emphasize the bedside manner. So,
are there any other questions?
Hi.
Hello.
Oh. So my question has to do with the tumor that the first one that's above his eye.
Sure.
So you said that there was some decaying tissue, and so I'm just kind of confused why you think that is, that the tumor would have part of it decaying.
Well, what happens when you have a tumor that's untreated, tumors are rapidly replicating cells, so eventually they outgrow their blood supply. So the ones right in the middle are going to outgrow their blood supply, and they're going to die and then necrose.
I see, and because it's basically on his face, you can actually see that.
Yeah, versus inside the body where you wouldn't be able to see that. The patient would just be very sick, may get...
And so basically it's not a spider bite.
No, so a lot of patients with skin cancer will say, oh, I have a spider bite, or a lot of patients with bacterial infections like MRSA, I'm sure you all have heard of, that's a characteristic spider bite lesion. So it starts off like that, and it gets red, and it starts with the cells replicating, but it doesn't go away. It just continues to grow and turn more into what you saw here.
Okay, cool, thank you.
I know you guys aren't medical policymakers, but, and I know most of the other talks today have been focused on really advanced engineering technologies, and it was really, your talk made me think about the socioeconomic differences in patient treatment if you don't have the money or the good insurance plan to pay for the advanced treatments, like just the ethical implications of that. I don't know if you can comment at all about that, but that really just struck us as we were sitting here like, yeah, he knows he has something wrong, but he can't do anything about it. And yeah, you can have more education, but if you can't be treated, then there's not much you can do about it.
With this specific patient, he was really lucky in that eventually he found the right people, and there was an OSF charity fund that actually funded his operation time and stay in the hospital, so he had minimal cost to him. And then the surgeons obviously saw the dilemma and donated their time and expertise also. So,
and that's also why we push the primary and secondary prevention, because you can limit your sun exposure, you can try and wear protective clothing, you can do the sunscreen. So it's best to prevent this altogether, but if you can't prevent it and it happens to you because of your phenotypic characteristics or genetics, you have light hair, a light complexion, then you do want to treat it early. And it's unfortunate with our health policy right now how some people don't have insurance and can't afford it while others can. And hopefully in the future, I don't know if anything is going to change, but hopefully people will get what they need.
I just want to make a comment. I'm Jonathan Lick. I'm head of hematology oncology at Northwestern University. We have to deal with this all the time, unfortunately, when we have patients come into the emergency room. Last night I was on the phone about a patient with a new case of leukemia who had to be seen in our clinic. We give free care all the time. Every institution does. The issue is there has to be an organized way to do it. Is it the first one in the door? Is it people with blue eyes? How do you do it? You have to do it in a very fair, unbiased way. Free care is given all the time, but it also affects all of us. This is why there's such a controversy over the individual mandate. If everyone buys car insurance, then insurance rates are low. If only some people buy car insurance and you get into a crash with someone who doesn't have insurance, then the whole system doesn't work. So it's going to be very interesting. We're at a very pivotal time right now to see what's going to happen with our ability to extend decent health care to all Americans. But I do want to assure you, and I'm very glad to hear that this person got very good therapy. So that's all I want to say right now.
And just an update on the patient. Oh, sorry.
Just to extend that, I'm from Boston, and in Massachusetts we don't really have this problem. Thank you, Governor Romney.
So a little update on the patient's status now. Fortunately, that lymph node that we felt was not cancerous. It came back negative. The imaging did show that there was invasion on imaging into the lacrimal gland. We dissected that out. That came back negative. We thought he was going to have local radiation and his eyesight would be gone on his right eye, but that didn't happen. So he's basically cured. He still has his eyesight, so we're thankful for that. He's very lucky.
Well, I probably shouldn't say this after the last comments that were very good, but I find it absolutely appalling that it took 2 hours, or 2 years for this person to be connected with the right resources. There are lots of charity organizations out there and other specific organizations, and the first time he walked to the doctor's office, they should have connected him right away, knowing that he was underinsured. And I find it incredibly irresponsible that our system allows these people to go for 2 years till it gets to this point when it was obvious that something was wrong.
I think he had alluded that there are a lot of patients in this donut hole, and you can only provide as much free care as your time allows you.
It's not about free care. It's about pointing them to the resources where they can actually get into a system. If he can't even be considered, you know, you have somebody, I mean, we have to get them, whether it's being prioritized by blue eyes, whatever, you know, get them connected with the right organizations, and that just is not happening.
Sure.
I just want to comment about that. We have extensive social services, both working in our faculty practice organization, as well as the Northwestern Memorial Hospital, that work with patients all the time to bring them to the proper set of resources, whether it be charitable organizations, emergency Medicaid, or the hospital and the doctors just waive the fees. My only point was that we do this, but it's not an organized system. You're absolutely right about that. That's because we don't have a healthcare system. We have a set of cottage industries that all sort of interlock in a fairly dysfunctional way. And until we grow up and be like every other Western nation, it's going to continue this way. But we are an exceptional country, and we're exceptional at being the only Western democracy to have this kind of dysfunctional health system. We will see in the next 6 months if we will evolve into something else.
Okay, with that, let's thank our speakers again.
Thank you. Thank you.